Great. Bismillahirrahmanirrahim. Thank you. I'd like to thank the organizers for the kind invitation, and hopefully I can stick to my time. A lot has happened in the past, let's say, 5 years in the field of migraine, and most of the updates that I have are pretty exciting. Okay. So this is a brief outline of what I'm going to talk about. Briefly, just a little bit about the burden of migraine. As internists, you guys probably see more migraine than I do. And I'll show you some of the data, not just globally, but also from the UAE. We'll talk a little bit about the pathophysiology of migraine. And why, and which is going to form the basis of the key updates in acute therapies and in preventive therapies. And then just a couple of slides on some of the promising new medications that are on the horizon in the next, let's say, few years. Okay, so moving on. So this is the global burden of disease study. We have another one after this, which is showing that the burden of migraine it keeps on increasing. So the prevalence of headache is about 47%. Primary headache cause substantial disability, and migraine tops the list. Not just because of the sheer number of migraines, but also because amongst all the primary headaches that we see, the disability that's attributable to migraine is so much more than the disability that is attributable to any other primary headache. And this is our own data from the Middle East. This is a study that was published by Dr. Tawfiq Al-Sabi, who practices in Abu Dhabi. I'm sure quite a few would be familiar with him. So this is a systematic review from a number of published studies from the Middle East region. And what it's basically showing is that women, obviously, globally also, they seem to be affected 2 to 2.5 times more than men. It tends to affect, individuals in the prime of their life, which is, the 20s and the 30s. And some of the key studies are showing the prevalence in the ranges of, 30%, 20%. Studies from Saudi Arabia, studies from Egypt and Northern Africa, Iraq, 26% prevalence, Morocco, 30% prevalence. So these are big numbers. Another very important thing that came out of this systematic review is the huge amount of comorbidities that these individuals have. So this is another important thing to keep in mind, because that has implication on the kind of medications that we are going to be talking about. This is another study that a group of neurologists from Dubai carried out recently. This was a study that was a retrospective analysis of real-world insurance data. And this basically is showing us that the migraine patient in Dubai is common, its treatment is costly, and it is largely undertreated with modern therapies. There were more than 200,000 patients that were included in the study. Mean age was 40, 55% of them were males. Majority were expatriates, which is the general demography of the city. And 13% of them had cardiovascular comorbidities, which is, again, important to keep in mind when we talk about newer therapies. Again, a very important thing to note here is that more than 50% of these patients were getting treatment not by neurologists, but by general medicine physicians, people like you. So they're not coming to us, they're coming to you for their treatments. So it's important for you to know what's out there to treat these patients. There was high treatment costs, there was low use of novel therapies, which I'm going to talk about. The median annual all-cause healthcare cost attributable was in excess of $1,000. Migraine-specific cost was 20%, and the treatments was mainly the use of non-steroidal anti-inflammatory drugs, only a third of these patients were getting triptans, which are migraine-specific treatments for acute treatment. And beta blockers, which you are all familiar with as a prophylactic treatment, was being given only to about 12% of these patients. Right. So I'll move on quickly to a little bit of pathophysiology. Not going into a lot of details, we have the vascular therapy and we have the neurovascular therapy. What's important is that there are various phases of migraines, and based on these phases, there is a vascular theory which suggests that migraine headaches occur primarily because of the vasodilation in the meningeal arteries, and a number of mediators are involved. Serotonin, a number of receptors, 5-HT1B, 1D, 1F receptors are involved in this. And then there is the neurovascular theory, where there are a lot of inflammatory mediators are involved. And it's important because these are the main targets of the new therapies that we are going to be talking about. These are all the mediators. I don't want you to remember them, but just so important to know, because these are, and this is how we've arrived at the new treatments that we are going to be talking about. Now, very quickly, there are two phases of migraines and two main treatments we talk about. There is the acute treatment in migraine, where when a patient gets an acute attack of migraine, there are kind of treatments that we offer them to abort that acute attack. And then there are the prophylactic treatments, which we offer to patients when they're having repeated or multiple attacks, recurrent attacks, and the burden is a lot more than just a one-off migraine. So in acute therapies, triptans are something that most of you are familiar with. They work on 5-HT1B and 1D receptors. The issue with triptans, so the way they work is that they work on trigeminal nerves and they prevent the release of CGRP. The newer medications we are talking about are called GPANs, and these are, and CGRP, they also work on CGRP, but they are, which is calcitonin G receptor peptides, but they are receptor antagonists, and they are potent vasodilators. They are not active vasoconstrictors as opposed to triptans. And that's where their big advantage over triptans lie. So these are medications that you can safely use in patients who have cardiovascular comorbidities and not pose them at any extra risks. Dietins are the other big group of medications which are new in the market, and they work on 5-HT1F receptors. They also do not cause vasoconstriction, and they are also safe in patients in cardiovascular disease. So these are the two new groups of medications for acute therapy that are now available for acute treatments in migraine. This is International Headache Society Guideline 2025. And the kind of data that we now have available, we never had before. So whatever treatments that we were using to abort migraines, the quality of the evidence was never that good. It was always moderate to low quality evidence, whether you were using naproxen to treat migraine or using brufen to treat migraine or using aspirin to treat migraine. Now we have very good evidence with triptans, of course, were always there, but now we have very good evidence with the new medications that I'm going to talk about, which are the GPANs, which I just showed you, and the dietins, which are the other new molecules. These are actually now available in UAE also. So we have ubrogepant, rimagepant, and zavegepant. These are the three new molecules. The FDA gave approvals in the recent 5-6 years. And then now even the zavegepant is now available in the UAE. The dietine, only lasmaditan, is the one that is currently approved, and it is also now available in the UAE. When should you use it? Well, the current recommendations are that for mild to moderate attacks, you should use non-steroidals first, non-opioid analgesics. And for moderate to severe attacks, which are not responding to the non-specific, you should go to these highly potent ones, the GPANs and the dieters, and use triptans. So these are the medications we are talking about. We have rimagepant, which is an orally disintegrating tablet. You can just put it on the tongue when the patient is having an aura, for example, or starting to get an attack, it dissolves, and usually the patient will start to respond within half an hour. The side effect profiles are very good. Usually, the most side effect these people feel is either a nausea or a hypersensitivity, which is a very rare thing. I've used it in many, many patients. Hardly anybody's come back with this. There are multiple trials. I'm not going to go into the details of any of those. Ubrogepant is another oral medication that you can use. Zivagepant is an intranasal preparation, so you just have to give it intranasally. Once in 24 hours, you can use it. The response, the main side effect is dysgeusia, so it's bitter to the taste, and that's it. No other. So with triptans, you have to explain they can get a chest tightness. With these medications, those side effects are not there. And then the only other ditan is the lesmeditan, which is not yet widely available, but it is found there in the market. Now, in terms of preventive therapy, again, preventive therapies also work on the CGRP molecule. We have ligand, these are monoclonal antibodies that are available for prevention of migraine. So they're not used in acute therapies, but as preventive medications. These are injectable, most of them. Two are, again, oral treatments. So you can have ligand-binding monoclonal antibodies, which are galcanezumab, tremonezumab, and eptinezumab. And you have a receptor-blocking monoclonal antibody, which is erinumab. All four are available. Tremonezumab is not available in UAE, but the other two are. And then you have receptor-blocking small molecules, rimegepant we just talked about, and atogepant, which are oral preparations, and I will kind of show you. So the International Headache Society guidelines, again, we have the high-quality evidence for all of these monoclonal antibodies. We never had high-quality evidence for any of the oral medications that we were previously using for migraine prophylaxis, be it topiramate, be it valproic acid, be it propranolol, candesartan, all the other oral medications that we were previously using and adapting from other diseases to use in migraine. We have even head-to-head trials of topiramate against one of these oral monoclonal antibodies, and the monoclonal antibodies have been shown to be, in fact, better than these oral medications. So these are the monoclonal antibodies that I'm talking about. How are they given? They're given as a once-monthly subcutaneous injection for erinumab, for galcanezumab, and for tremonezumab. And eptinezumab is given as once in 3 months intravenous injection. Side effect profiles are again excellent. The most side effect people complain of is constipation. Other than that, they're generally very well tolerated. These are the oral Gepants that can also be given as preventive treatments. Botox is recommended also for chronic migraine. It's not new, but it has been there for a very long time. So I just thought that I will put this out there. It's also considered as a first-line treatment for chronic migraine. So these were the key updates in terms of new treatments. They're considered, at least for preventive therapy, they're considered as first-line therapy in international guidelines now. For acute treatments, they're not yet considered as first-line treatment. It's recommended that you should try the triptans as first-line. If somebody is not responding to triptans, then you should move on for moderate to severe migraine to one of these Gepants or ditans. What are we looking at in future? A number of other peptides have been identified, not just peptides, ion channels as well. And there are medications that are in phase 2 and phase 3 developmental stages targeting these molecules. These are just some of them that I've put here. So watch out for some of these new medications that might be in the market very soon. So just to conclude, despite high disease burden, migraine remains underdiagnosed and undertreated across the Middle East. Acute therapies including Gepants and ditans. They offer quick and effective pain relief with fewer side effects. new preventive therapies, including monoclonal antibodies against CGRP ligands and receptors, as well as GPENs. They've proven both effective in both episodic and chronic migraine, and they should be offered to patients sooner than later, because it does pose a huge burden to patients, and you can really help your patients by reducing the migraine burden. Thank you.